In this session, we are going to talk about the anatomy of the lacrimal apparatus, both its secreting portion and its drainage portion. The lacrimal secretory system is made up of the main lacrimal gland as well as the accessory lacrimal glands, and the drainage system is made up of the puncti, canaliculi and the nasolacrimal sac with the duct. The main lacrimal gland lies in the superiotemporal orbit, in the lacrimal fossa of the orbital plate of the frontal bone in the roof of the orbit. The lacrimal gland is divided into two lobes, the upper larger orbital lobe and the lower smaller palpebral lobe, and this division of the main lacrimal gland into the two lobes is made up by an indentation created by the lateral horn of the LPS aponeurosis. Fibers from the Whitnall's ligament also pass through the lacrimal gland. We have described the anatomy of the LPSA and the Whitnall's ligament in detail in the previous sessions. The lacrimal ducts originate from the lacrimal gland and open in the conjunctival sac, and they are 8 to 12 in number, and all the lacrimal ducts pass through the palpebral lobe before draining in the conjunctival cul-de-sac. To minimize damage to these lacrimal ducts, lacrimal gland biopsy should be restricted to the orbital lobe, because if the biopsy is taken from the palpebral lobe, ducts from both the palpebral lobe as well as the orbital lobe can be damaged. The lacrimal ducts open into the superior fornix after passing anteriorly through the levator palpebris superioris aponeurosis and the Muller's muscle, and it opens into the superior fornix 5 mm above the superior border of the lateral portion of the superior tarsus. The accessory lacrimal glands are located in the conjunctival submucosa, and those located in the superior and inferior conjunctival fornices are called accessory lacrimal glands of Krause, and those located along the superior border of the superior tarsus and the inferior border of the inferior tarsus are called the accessory lacrimal glands of Wolfring. We have described the tear or the lacrimal reflex arc in neuro-ophthalmology, and this reflex arc helps in secretion of tears upon conjunctival stimulation. The afferent path of this tear reflex arc is provided by the trigeminal nerve or the fifth cranial nerve, and the efferent path of this reflex arc is provided by the seventh cranial nerve or the facial nerve. Previously, it was considered that the accessory lacrimal glands provided the basic secretion and the main lacrimal gland provided the secretion following conjunctival stimulation. But now, the main and the accessory lacrimal glands are thought to act as an unit. The lacrimal drainage system starts at the puncta and ends at the opening of the nasolacrimal duct in the nasal cavity, and the puncta are located in the medial eyelid margins over a slight elevation called the papilla, and the papilla are oriented slightly posteriorly so that the puncta remain in contact with the globe and the tear leg. This blue line represents the tear leg along the eyelid margin, and volume wise it contains the majority portion of the tears within the tear film. The inferior puncta are slightly lateral to the superior puncta, and on average the punctal opening is 0.3 mm in diameter. The upper and the lower canaliculi both have a vertical portion and a horizontal portion. The vertical segment is also called the ampulla, and the horizontal segment is around 8 to 10 mm in length. A common segment or common canaliculus is formed by the joining of the upper and the lower canaliculi, and this common canaliculus opens into the lacrimal sac. Sometimes the common segment is absent and the upper and the lower canaliculi open into the lacrimal sac separately. At the junction of the common canaliculus and the lacrimal sac, reflux of tears from the sac into the canaliculus is prevented by a mucosal fold, also called the valve of Rosenmuller, and the bending of the common canaliculus forwards, where it opposes with the medial canthal tendon. In the previous session, we had learned that the posterior arm of the medial canthal tendon passes posteriorly between the two canaliculi to reach the posterior lacrimal crest. The canaliculi are lined by non-keratinized stratified squamous epithelium which do not secrete mucus, and there is a sodium and iodide transporter present in this epithelium, which is said to be the reason why canalicular stenosis may occur after radioactive iodine treatment for thyroid cancer. Coming to the lacrimal sac, the lacrimal sac is located within a bony fossa called the lacrimal fossa on the medial orbital wall, bounded anteriorly by the anterior lacrimal crest and posteriorly by the posterior lacrimal crest. We have discussed this anatomy when we discussed the anatomy of the medial orbital wall in the session on anatomy of the orbit. The supero-inferior length of the lacrimal sac is said to be 12 to 15 mm on average, and anterior to the lacrimal sac we have the anterior arm of the medial canthal tendon attaching to the anterior lacrimal crest. Posterior to the lacrimal sac lies the posterior arm of the medial canthal tendon attaching to the posterior lacrimal crest, and lateral to the lacrimal sac the two arms, the anterior and the posterior, of the medial canthal tendon fuse to form the middle part of the medial canthal tendon. Medial to the lacrimal sac, the frontal process of the maxillary bone forms the anterior part of the bony lacrimal fossa, and the lacrimal bone forms the posterior part of the bony lacrimal fossa. Medial to the medial orbital wall in the region of the lacrimal fossa lies the ethmoid sinus, and intranasally the lateral wall of the middle meatus anterior to the middle turbinate lies at the level of the lacrimal sac. Superiorly, the lacrimal sac extends above the level of the MCT and is called the fundus of the lacrimal sac. Inferiorly, the lacrimal sac is continuous with the nasolacrimal duct. Structures which are prone to get damaged during lacrimal sac surgery are the angular artery and vein and the terminal fibers of the zygomatic and buccal branches of the seventh cranial nerve. The nasolacrimal duct drains 80 to 90% of the tear volume, and the remaining 10 to 20% of the tear volume evaporates. Length of the nasolacrimal duct is 18 mm on average, and it has two parts, the intraosseous part and the meatal part. The intraosseous part lies within the bony nasolacrimal canal and is 12 mm in length, and this nasolacrimal canal is directed inferiorly and slightly posteriorly and laterally, and this direction is very important when probing needs to be done for congenital nasolacrimal duct obstruction. And the meatal part, which lies within the mucous membrane of the inferior meatus of the nose and is 6 mm in length. The nasolacrimal canal opens in the inferior meatus inferior to the inferior turbinate and is guarded partially by a mucosal fold called the valve of Hassner, and this opening lies 30 mm behind the anterior nares. So intranasally, the opening of the nasolacrimal duct is in the inferior meatus and the nasolacrimal sac lies at the level of the middle meatus. The lacrimal pump is very important to understand and is responsible for pushing the tears towards the lacrimal sac and into the nose. During eyelid closure caused by contraction of the orbicularis, the pretarsal orbicularis compresses the puncta and the canaliculi, thus increasing the pressure within the canaliculi. During eyelid closure, the puncta also come in contact with the opposite lids and are occluded. So what is happening is, during eyelid closure, the pretarsal orbicularis is increasing the pressure within the canaliculi, and the tears are not able to escape through the puncta and are pushed forwards towards the lacrimal sac, and the preseptal orbicularis compresses the lacrimal sac, pushing tears already in the lacrimal sac further into the nasolacrimal duct and in the nasal cavity. During eyelid closure, upper and lower lid starts apposing from the lateral canthus, and the apposition progresses from the lateral canthus towards the medial canthus and completes at the medial canthus, thus shifting the tears in the tear leg from lateral to medial towards the puncta. Now when the eyelid opens and the orbicularis relax, the empty puncta and the canaliculi as well as the empty sac open up, creating negative pressure within them, which draws tears from the tear leg to the drainage system. Lacrimal flow is further facilitated by progressive increase in the caliber of the lacrimal drainage passage, by gravity, by low pressure in the nose due to respiratory airflow, and by unidirectional valves, which we have discussed. Thank you for listening.